Hi everybody. Today we are going to learn about prone position and how prone position helps to improve ventilation and perfusion in ARDS or in COVID-19 patients. So what is prone position? In prone position, patient is positioned with face down, laying flat on the stomach. And why do we prone patient, or what are the indications of prone position? The indication includes ARDS, acute respiratory distress syndrome, or COVID-19 when the PF ratio is less than 200, or there is refractory hypoxemia. That means you are providing high amount of oxygen, IFiO2, but the patient still remain hypoxic. It is the benefits of prone position is seen, or the better outcome of prone position is seen when you initiate proning or when you encourage patient to prone as early as possible or less than 48 hours of diagnosis. You also prone patient in certain surgical procedures where surgeon need access to the back or surgeon need access to the dorsal area. Example, spinal surgery. In those cases, we do position the patient in prone. So now, before going into the benefits, you should know what is ventilation and what is perfusion of the lungs. So what is ventilation? Ventilation means the amount or the rate of air moving in and out of the lungs. And ventilation is abbreviated as V. Whereas perfusion is the rate or amount of blood that flows in and out of the lung. And perfusion is abbreviated as Q. So in order for a proper gas exchange or lung function, there should be ventilation and there should be perfusion. That means air should flow in and out of the lungs and there should be adequate blood flow throughout the lungs. If there is ventilation and perfusion is not there, gas exchange may not happen. Same way, if there is blood flow, if there is perfusion and if there is no ventilation, something obstructing the airway and there is no air flow, gas exchange won't happen. So for proper lung function or for proper gas exchange, ventilation and perfusion should match. So what is ventilation-perfusion mismatch? If you look at this diagram, you can see alveoli and the blue color, the air is moving in and out of the lungs or in and out of the alveoli. And you can see the capillaries that surrounds the alveoli carries blood. So as the blood moves through the capillaries around the alveoli, gas exchange will take place. That means carbon dioxide moves out to the alveoli, oxygen moves in, and the carbon dioxide in the alveoli is exhaled out. So there is a gas exchange. So there is ventilation and there is perfusion. Now look at this alveoli where you can see the blood is flowing, but ventilation, the air is obstructed. So when the air is obstructed, but there is blood flow, the gas exchange, there is no gas exchange or gas exchange is impaired. Same way, if there is air flow, you can see that there is air flow into the alveoli, but let's see a blood clotting, and there is no blood flow through the capillaries that surrounds the alveoli, gas exchange won't take place. That is called as ventilation-perfusion mismatch. So if there is a mismatch, remember there is impaired gas exchange or gas exchange won't happen in the lungs. So how is ventilation and perfusion throughout the lungs? So the ventilation and perfusion is not even or not equal throughout the lung. If you divide the lung into three zones, zone A, the apex, and middle zone, and zone C is the base of the lung. If you take the alveoli in each zone, you can see the alveolar size decreases as it goes down. The alveoli at the apex is bigger, smaller, and at the base, it is the smallest. This is because of the high pleural pressure at the dependent area. If you compare this lung to a rubber band and you stretch the rubber band down, you know the lungs is elastic, and you stretch the rubber band down, definitely the size decreases as it goes down. Same way, the lungs is covered by pleural membrane, and the outer pleural membrane is attached to the chest wall, and consider it as a rubber band which is hanging down. There is more pressure towards the base, or in the pleural pressure, there is more pressure. As a result, the alveoli towards the bottom decreases the size. Even though the alveoli decrease in size towards the base, it is more distensible. It can more expand and collapse. So remember, when there is air moves in and out of the lungs, the alveoli expands and relax. When it expands, it fills the air, and when it collapses, it spews out carbon dioxide out of the lungs. So towards the base, the lungs are more distensible. They can do more, they can expand and collapse. As a result, ventilation increases from apex to base. And if you look at the perfusion also, the heart is at the center. To pump blood towards the apex, the heart has to overcome the gravitational force, whereas towards the base, it is more easy because there's minimal gravitational force. So same like ventilation, perfusion increases from apex to base. More than gravitational force, the perfusion is always high in the dorsal or towards the base or towards the dorsal area. It's because of the vascular structure of the lungs. So the key point is the ventilation and perfusion is not even throughout the lung. Ventilation improves from apex to base. Same, perfusion also increases from apex to base. So what about VQ ratio? Because VQ ratio, remember, ventilation perfusion ratio indicates the gas exchange. So as we discussed, in zone 1, the ventilation is low, whereas perfusion is, compared to ventilation, is significantly low. So the VQ ratio, which indicates the gas exchange, if you look at the ratio, the denominator, the Q, is smaller than ventilation. So if the denominator is low, the VQ ratio will be high. So in apex, VQ ratio is high. Whereas when you go to zone 2 or middle zone, V increases, Q also increases. So there is a match. When you come to zone 3 or base, from apex to base, ventilation increases and perfusion also increases. But perfusion increases more than ventilation is because of the vascular structure, or there is more vascular towards the base of the lung. So the denominator is more than numerator, the VQ ratio drops. So to summarize, in lungs, ventilation increases from apex to base, perfusion also increases from apex to base. But for gas exchange, we look at the VQ ratio. So if you look at the VQ ratio actually drops from ventilation from apex to base. And this is because the perfusion increases more than ventilation. So remember, ventilation and perfusion is not even, it's more towards the lower zone. And the ventilation is less increased towards the lower zone than perfusion, because perfusion increases more than ventilation. And the VQ ratio, which indicates the gas exchange, that drops from apex to base. Perfusion is more increased towards the lower zone than ventilation. So since the perfusion is more increased, perfusion Q, that is the denominator, it increases towards the base more than ventilation. If you look at the VQ ratio drops. VQ ratio is less towards the lower zone. So how does prone position helps to improve VQ ratio or gas exchange? Or how does it help in ARDS or in COVID-19 patients? If you look at this picture, you can see when the patient is supine, the heart is resting on a portion of the lung, that is the dorsal area. Dorsal area means towards the spine. So the heart is resting towards the dorsal area, and the abdominal contents are pushing the diaphragm. When it pushes the diaphragm, it moves towards the cranial, or it moves towards the lungs. As a result, in the dorsal area, there is more pressure from the heart as well as the abdominal content. So it can lead to collapse of the dorsal alveoli. But when you prone the patient, you can see now the heart is resting on the sternum. As a result, there is no compressive effect on the lung. The dorsal alveoli is no more compressed. Same way, when you prone the patient, this is the dorsal alveoli, where now the spine is up. So there is no compression from the abdominal contents. As a result, the dorsal alveoli is better aerated, is better ventilated now. So you are eliminating the compressive effect of the heart and the GI content when you prone the patient. As a result, the dorsal alveoli or alveoli towards the spine are better aerated. Along with it, if you look at the ventral alveoli or alveoli at the top, these are over distended. The reason is in ARDS or in COVID-19, this alveoli is filled with fluid. So the ventral alveoli is over distended. It cannot involve in ventilation properly. These all are over distended. But if you look at the distal alveoli towards the bottom, it is collapsed. It's because of the weight of the lung. Because this lung is all filled with fluids, and because of the weight of this wet lung, the dorsal alveoli is collapsed. So the ventral alveoli is over distended and dorsal alveoli is collapsed. But when you prone the patient, what happened is ventral alveoli is at the bottom now. It becomes less distended because of the weight. And the dorsal alveoli is at the top now. So there is no compressive effect of the heart, there is no compressive effect of the GI content, and there is no weight of the wet lung. As a result, the dorsal alveoli can expand now. So there is decreased collapse of the dorsal alveoli. So it can better involve in ventilation. So there is an increase in ventilation in the dorsal alveoli. Along with the increase in ventilation, irrespective of whether the patient is in supine or prone, always the perfusion, the blood supply is more in the dorsal area. This is because of the vascular structure of the lung. So there is increase in ventilation to the dorsal alveoli and there is good perfusion. So you are increasing the ventilation and good perfusion. So it matches. As a result, gas exchange improves. So this improved VQ mismatch or VQ mismatch is corrected there when you prone the patient. Along with the correction, the mouth, the nose is facing down. So it facilitates the drainage of secretion and better aeration of the lungs. So now let's conclude. What are the benefits of prone position? It improves VQ mismatch. It improves ventilation in the dependent area or in the dorsal area. It decreases the shunt. Shunt means there was ventilation, there was perfusion, but there was no ventilation. It's because the dorsal alveoli is collapsed. So when you prone the patient, the dorsal alveoli can expand and involve in ventilation. There is improved ventilation where perfusion remains the same. You're decreasing the compression of the heart and the abdominal content. You're decreasing the mortality. So you're preventing the ventilator-associated lung injury. And it also enhances the mobilization of secretion. So today we discussed about prone position and the advantages of prone position in ARDS and COVID-19. Thank you for watching my video.